Today we have the honor and the privilege to have Mr. Kip Sullivan. He's been a friend of single payer for some time, very knowledgeable, and he's my go-to guy. Every time I get questions or the editor or whatever, I burn emails to this guy, and he kindly sends them back to me all the time. I appreciate that very much. But he began his career as a staff attorney for the New York Legal Aid Society and as a researcher for Citizens Action League in California. From 1980s through 2000, he researched universal health insurance and a single-payer system for Minnesota. He has also served as a consumer representative in the Minnesota Governor's Health Plan Regulatory Reform Commission in the 1980s. From 2000 to 2007, Mr. Sullivan was a health system analyst for the Minnesota Universal Healthcare Coalition. Mr. Sullivan has written over 150 health policy articles for the American Journal of Public Health, the Journal of Health Politics, Policy and Law, the LA Times, the Nation, the New England Journal of Medicine. So the bottom line is, if you see his name somewhere, yes, it's probably this guy that wrote that article. He published in 2006 The Healthcare Mess, how we got into it and how we get out of it. And Mr. Sullivan earned his law degree from the Harvard School of Law. He has an undergraduate from
Pomona.
I couldn't pronounce it, so I just had to go that way. So ladies and gentlemen, Mr. Sullivan.
Yeah. I didn't realize Paul was going to read all that. What I'd like to emphasize is that I majored in economics, I did go to law school, but I fell in love with community organizing in 1976 out in the Bay Area, where I had gone actually thinking I would play music professionally, and I got some arthritis in my fingers that made that impossible. And thinking that I was just temporarily slipping the fingers, I went to work for a community organization called Citizens Action League, started by a couple of Saul Alinsky's lieutenants, and boy, I fell in love with community organizing. The idea of making democracies work by giving people power, teaching people how to run meetings, how to select issues, how to hold elected people accountable. And I grew up in Minnesota, and I came back here in 1980, and the same year that Don Pilkinen joined Minnesota COAC, I was hired. I think, John, you were the lead organizer in
Central Minnesota.
In Central Minnesota. I was assigned to Mankato, and that was early 80s when the Minnesota farm crisis hit following the recession. And we were working with Paul Wellstone to stop farm foreclosures. And it became apparent to us, this was, as you can imagine, long before healthcare crisis is in the headlines, we were finding that farm families that are on the ropes, one of the first things they do is either drop health insurance or buy health insurance with god-awful deductibles. You know, $1,000 per person for a family of 4 in 1980. And we started researching it, and in the summer of '86, Minnesota COAC and the Minnesota Senior Federation got together and decided, let's pull in a whole bunch of other groups, MNA, Minnesota Nurses Association, Public Employees Union, and we didn't stop. We brought in group health and the Hospital Association, and created the first universal health insurance coalition in Minnesota called the Healthcare Campaign in Minnesota. It was actually Ed Ellinger who suggested that name, because Ed was part of the conspiracy. And I was pulled up from Mankato, and our director, John Music at the time, said to me the board is seriously considering undertaking a campaign for universal health insurance in Minnesota, possibly at the national level if that becomes feasible. Would you be interested in directing the campaign? And I remember being both excited and overwhelmed. And here I am, one highly educated, graduate degree, did well in college economics, voracious, omnivorous reader of everything under the sun, and I just didn't know that I could grasp this business of health policy. I mean, I didn't know what a teaching hospital was. You name a piece of jargon in health policy or medicine, I didn't know much about it. But I thought, well, throw me in the water and I'll swim. And that was 86. And so, thank you, Paul, for all that wonderful, but I'm totally self-taught. And I think it's a benefit that I did not go through the University of Minnesota or any other graduate school in America and learn this nonsense. They're teaching people about what's causing the healthcare crisis and how to solve it. I hadn't intended to give you all that, but I had to respond to Paul's accolades. What we're going to do today is compare a brand new single-payer bill that's been introduced in the U.S. House of Representatives on February 27th by Representative Pramila Jayapal. The number is HR1384, and we're going to compare it to the bill that Senator Bernie Sanders introduced in September of 2017, S1804. As you may know, for a long time, the gold standard for single-payer legislation in America was HR1384. The chief author was Representative John Conyers. He stepped down early in, 2018, and Keith Ellison had volunteered to step forward to replace Representative Conyers as the chief author. And then to his surprise, he found, well, you all Minnesotans know the history, he wound up running for AG, and he made that decision in June after the DFL convention here, and Representative Jayapal volunteered to be the chief author of, at that time, what was HR 676, but she said, I want to rewrite it. And we were a little concerned about that because she's new, and she said, I want to rewrite it to make it look like Senator Bernie Sanders' bill, and that really scared a lot of us because, as I want to show you today, there are some serious defects in Bernie's bill. I'm a huge fan of Bernie, love him. I appreciate that he's made single payer a household word, or helped us make it the household word after all of this organizing so many of us have been putting in all these years. But his bill is seriously defective, and he's going to introduce a new version for this session in a couple of weeks is what I hear, and it'll have a different name. My concern is that it's going to look a lot like S1804. So, and I'm also going to talk a little bit today, just by way of illustration, about our own Minnesota single-payer bill. The chief author in the Senate is John Marty. That's SF1125. And the new chief author in the House is Representative Elise Mann. I just heard her name pronounced the other day by John Marty at our PNHP meeting at the university last weekend. I have never met her, but I look forward to meeting her. And those two bills were reintroduced with new numbers in February of last month. And just a word to the wise, when you see HR 1384, it does not mean House resolution. Somebody just emailed me with that phrase. I said, nope, that means House of Representatives, 1384. Of course, S before 1804 means Senate. Here in Minnesota, we don't say that. We say SF, Senate file, and HF, House file. In other states, they go SB and HB, meaning House bill and Senate bill. So if we've got time, I want to talk briefly about the buy-in bills. There are so-called Medicare buy-in bills being introduced in Congress. And here in Minnesota for the last couple of years, we've heard a lot of interest in something called the Minnesota Care buy-in. When you're talking about evaluating legislation, usually you have four criteria. Cost, does it contain cost? Is it universal? Does it cover everybody? Is the coverage comprehensive? Does it cover dental or not? Are the deductibles non-existent? And then financing. How is it financed? And what you really want is to see progressive financing, not regressive financing. The sales tax is regressive. It takes a bigger percent of the income of a poor person than a rich person. Conversely, the individual income tax is progressive. As you get richer, it takes a bigger percentage of your income, not just more money. It takes a bigger percentage of your income. That's what a progressive tax is. The new bill that Representative Jayapal has introduced is a very good bill. It has excellent cost containment, it's universal, and the coverage is comprehensive, quite comprehensive, with no cost sharing. Where it's weak is in financing. For some reason, when she rewrote HR 676, she stripped out the 4 progressive taxes that were listed in HR 676 as the financing sources. I presume she did that because she thought it would make the bill easier to pass. I realize that's probably a judgment call, but if you ask my opinion, I would say that doesn't make it any easier to pass. Our opponents are going to make up all kinds of stuff, and if you just leave that part blank, they're going to make something up, and it's probably going to be worse than the reality of the bill of the taxes you took out. I want to start by defining what a single-payer system is. The label single-payer is being increasingly muddied up, in part by people who are defining Medicare for all as something we don't think it is, and in part because there are bills like Bernie Sanders' bill, which has got serious problems with it, that's also being called a single-payer bill. So I think it's really important that we learn how to draw a bright white line around what a single-payer is. It has 4 features. Number 1, it means one payer replaces multiple insurers. So at the national level, Representative Jayapal's bill means the Department of Health and Human Services is going to replace 1,000 to 1,500 insurance companies. It's very unclear how many insurance companies we have in this country. It's probably around 1,000. And in Minnesota, it means one payer replaces probably 300 insurance companies. The second feature is that the one payer at the federal level, I'm going to say HHS, Department of Health and Human Services, sets budgets for institutional providers. And you'll see it in some single-payer bills. They divide all healthcare professionals and institutions into institutional providers, hospitals and nursing homes, and then into individual providers, mainly doctors, but chiropractors and acupuncturists, dentists, etc. So the second feature of a single payer is that it sets budgets for institutional providers, annual budgets. Third, it sets a uniform fee schedule for mainly individual providers, doctors. And then fourth, it sets price controls on drugs. And this was essentially the model proposed in 1989 by a group that was new at the time, Physicians for a National Health Program. They're now up to about 21,000 physicians. They were formed in 1986. Their founders are David Himmelstein and Steffi Woolhandler. Amazing researchers, those two. And the reason I say this is the definition is not because I went to the mountain and I got a scripture and this is what a single payer is. This is the definition because if you mess with any of these features, you reduce the ability of the single payer system to cut costs. It's that simple. I will show you some slides documenting that statement. 1384, Pramila Jayapal's new bill, has all 4 elements. Bernie's is missing the first 3. And in a minute I'm going to show you a classic feature of every single payer bill. Every single payer bill, true single payer bill, will have a statement in it that says, on such and such a date, it shall be unlawful for an insurance company to sell a policy that duplicates the coverage described in this bill. And that usually tells you that you're reading a single payer bill. The trouble with Bernie's bill is he has that prohibition in it, but 4 or 5 pages later, he's got a section that authorizes a brand new type of insurance company called accountable care organizations. And nobody knows what ACOs are, but they act and walk and quack like insurance companies. And everybody overlooks it. Everybody who studies his bill says nothing about it. But people who understand health policy, including PNHP at the national level, and have strenuously objected to it privately. We were very worried when Representative Jayapal said from about June through October, I want to synchronize HR 676 with Bernie's bill we were really concerned that she was going to do what Bernie did, which was to insert ACO, Accountable Care Organization, loopholes in the bill and yet retain that classic statement on such and such a date, insurance companies can't sell policies that duplicate the coverage. Turned out she did not. I was thrilled to read the final bill. I would say her bill is a slight improvement over HR 676. It's about 120 pages long. HR 676 was 30 pages long. I don't think it needed 120 pages, but a lot of it really is an improvement. Now I want to come back to this issue of why is a single payer, why do I define a single payer bill according to whether it can contain cost or not. It's not because single payer advocates are sectarian and think it's got to have these features or you're not part of our tribe. If you take any of those 4 features out, you lose savings. Now I want to call your attention, this is a list that I drew up based upon a half dozen studies, including a study of HR 676. If you ask how much a single payer bill can save, the answer is probably on the order of 15 to 20%, if you don't touch provider income. So you can say to every hospital and doctor in America, we're not proposing to slash physician and hospital income on average. We're going to raise Medicaid rates, we're going to bring some other types of payment down, but on average, provider reimbursement doesn't change. That's essentially what the argument was for HR 676, and when we get to it, you'll see that Pramila has adopted roughly that strategy. Bernie didn't. Bernie's bill says rates will come down to Medicare levels. And I think you all know that a study put out by a conservative think tank called the Mercatus, I can't remember what the Mercatus something or other, came out with a report that said Bernie's bill will save a little money, but only by slashing provider, doctor, and hospital rates by 40%. That's a gross misrepresentation of what a single payer can do. And of course they would say that. They're not about to give single payer its due. But anyway, if you ask, let me just jump ahead here and see if I can. If you ask, where is my, here we go. If you ask, well, what about a system like Canada, which is spending half what we're spending? So Kip, why are you standing up there and telling me that an American single payer bill can only cut costs by 15 to 20%? Why isn't it 50%? Well, there's a twofold answer. The Canadians don't offer, they don't cover a lot of things. They don't cover dental care. I think they've started to take a crack at long-term care. Their drug coverage is very weak. I think they offer coverage to poor people. So that's one reason. The coverage in Canada is often described as deep and narrow. And then there's a whole, so physician and hospital coverage is excellent. But there's a lot of stuff that's not covered. So that's one reason why we can't claim to get to Canadian levels, because we're going to offer a lot better coverage. The other reason is we're not proposing immediately or even in the short term to get physician and hospital reimbursement rates down to Canadian levels. So if you do those two things, you offer much richer coverage and you forego the opportunities to use the power that comes with a single payer to reduce physician and hospital and other provider pay to Canadian levels, then you're talking more like a 15 to 20% savings. Now what that means is, to come back to my last slide, what it means is that instead of being able to cut by 40 to 50%, you see the total savings there is probably on the order of 15 to 20%. And then you have to offset that with increased utilization or consumption of medical care. And there's two reasons. Number one, there's no more uninsured people. And uninsured people use about half the services that insured people use. So if you say we're going to insure the uninsured, that will drive up utilization, and it should. And if you say we're going to eliminate out-of-pocket payments, well, shoot, you've got 90% of Americans who have insurance, but big out-of-pocket payments, and now you're bringing those down too. So that will increase utilization slightly as well. And that combination then is and you add long-term care. That's an expensive piece of any universal coverage bill. Your total utilization is probably going to go up 15 to 20%. Now, you look at a lot of other research out there, you'll see some people predicting a utilization rate of 8%. You may all recall that Growth and Justice put out a report on single payer that they cooked up. And the Lewin group said utilization will only go up 8%. When I see a number like that, I'm thinking, no, they just didn't offer the coverage that HR1384 and our Minnesota Care Bill, our Minnesota Health Plan Bill, or the new Promella's new bill is offering. So keep that in mind because that might be an option. You may want to say, well, we do want to bring some provider reimbursement rate down in order to increase savings.
Yep.
Yes.
I keep hearing 30% savings on administrative costs. But that also includes marketing and all that kind of stuff. But you've got 10 to 15%, half. Is it 10-15% per side, or is it just 10 to 15%?
That 30% number you ever hear his question, he hears that the total wasted amount in administration is 30%. That 30% number you're hearing is the total amount that America spends on administration. Now that doesn't mean that 30, 31, 32% is totally wasted. I mean, every human enterprise has to have some administrative cost. A high school choir has an administrative cost. We think that Canada operates, they devote 15% of their entire healthcare bill to administration. We're devoting 30, 31, 32%. And so when you see in the top line there, savings of 10 to 15%, that's based on a couple of studies that have, some that have used Canada as a model and others that have used others. I think 15% is realistic. I don't think it's realistic at the state level because we're still going to have Medicare and Medicaid initially. But at the national level, I think you could bring total administrative spending down from 30% of our total bill to 15%. And what I meant to say by this line here was that half of that 10 to 15% savings is from the insurer sector, because now you're going to one payer, and the insurance industry operates with 20% overhead, and you're going to get that down to about 2%, which is what Medicare operates at. And then there's the provider sector. Hospitals and doctors have overhead. It is very high because we're in a multiple payer system, and the 1,000 insurance companies all have their own hoops for everybody to jump through, and to turn the doctors into data entry clerks in order to make them document what they're doing and show quality. And so when you go to a single payer system, you're reducing the overhead of the insurer sector and the provider sector. That's where you get that 10 to 15%. Is that making?
Yes. Now the other question that goes right with it. Senator Jensen's been talking about all the paperwork that he has to do on every patient. He has to document everything. With single payer, we'll be able to eliminate a lot of that, all that paperwork.
No, you will. We will for hospitals. We will not eliminate paperwork for physicians. What we will do is make the paperwork uniform. It would be going to the uniform fee schedule like Medicare for doctors. And thanks to Pramila Jayapal's new bill, she's going to strip out all of that quality control, value-based payment stuff that is turning doctors into data entry clerks. So two things will happen. The billing rules will now become uniform, and there will be no more of this constant intervention with you have to buy electronic medical records, you have to click on a box that said, did you talk to the patient about not smoking? Do you understand that diabetics have to have their kidneys examined once a year? Please click on the box and say, tell us you did that. All that's going to go away.
Kip, could you comment on the drug prices? It seems like if we could negotiate drug prices, we might be able to do better than 4% savings, or I'm not sure. I understand that.
I probably should have said right away, these percentages are all as a percent of the 3.5 trillion we spend on healthcare nationally. And so if I say drug price controls are going to save 4%, I mean it's going to reduce the 3.5 trillion by 4%. It will probably, I think what you're thinking is what will happen to the average drug. Our drug prices are insane compared to countries that actually try to control it. So I think if you were to ask me what's going to happen to the average drug price, I think it's going to drop by 20 to 30%, possibly. Some of them are going to drop by half. But good question. Thank you for reminding me. Yeah, everybody understand what I'm measuring here. This is a percent of the total healthcare bill. So what I'm trying to, and this is a critical, I mean, I think you all who are following this know how critical this is. We are and will always be attacked on the ground that we can't afford this. And the answer is we can't afford not to, because this is the only solution that can cut total spending by 15 to 20% minimum, or possibly more. So it's really important that you understand, you can say with a straight face, we can cut the $3.5 trillion bill by 15 to 20% in a fairly short period of time and still cover everyone. Yes?
Well, Kip, I think you're going to be able to save even more money if the doctors are allowed to see people longer. Because I have a friend who is a doctor, and she's always telling me that she spends the amount of time she needs to, and she's found so many things that other doctors have just seen. And I feel like that when I'm in a doctor's office, I'm whatever organ they're looking at that time, and the rest of me isn't really there. And so I think actually we're going to end up after a few years saving more, because if people get sicker before they're diagnosed, that's more expensive. And I think that's what's happening. Plus, they're over-drugging people.
Right.
Just over-drugging.
Well, keep in mind, I hear that argument often, that if we keep people healthier, costs will go down. We don't have any evidence for that. We just need to do it on the ground. Making people healthier is a good thing. You may recall that when Humphrey and some other state AGs sued the tobacco industry in order to get back money from Medicaid that Minnesota and other states had paid out, the tobacco industry responded, we saved you money because we killed those people off early. Just keep that in mind. And I don't know how well it went with the court and jury, but they had evidence to show their case. You kill them off with lung cancer at age 55, they're not around to get dementia and Alzheimer's and arthritis and qualify for Social Security. But let's do it.
That's my national duty.
Yes.
Can we just hear from Kip and then do Q&A after this?
Let's do that. One more question. This is critical. Go ahead.
Well, it's about the drug or the medication prices. I think part of what's confusing for people is to understand that most people pay co-pays and deductions for their meds at the really high price. So the 2% saving not only is it for the overall budget, but it's also for the fact that the drug prices are being absorbed into this new program. And so that's also going to bring the savings to be less, because that's something that's going to be covered 100%. We're all going to get our meds 100%.
Well, I think you're saying, again, that good medicine will actually more than pay for itself because people can get healthier. I don't believe that we have evidence to support that.
No, I'm not saying that.
Oh, okay.
I'm saying about medications, pharmaceuticals are, right now we pay high co-pays to get our pharmaceuticals, plus they're at a high rate. But that rate, even though it's going to come down, and it's spread across the whole budget for what you pay. So the savings was 2% for the whole budget, but we also have to pay. We weren't covering it for a lot of people, so people were paying a lot of out of pocket for their meds.
Yes.
So that's going to be covered now.
Yes, which means more people are going to be buying drugs, which is one reason why you see utilization going up, which is a good thing.
Yeah, well, so they can afford their insulin and their
Yes.
blood pressure meds.
Yes, yes,
And it'll be a more reasonable price
right.
for the system, but it'll be less savings than you would think because of that.
So now what I want to do is just show you some quick numbers to justify what I just said about administrative costs. If you ask about, and this, Paul, gets to your question again, remember now, Paul's question was about how much of the entire national health care bill gets spent on administration. And the answer is somewhere between 30 and 35%. We're going to pull that down to maybe 15% at the national level. So we've got 15% of $3.5 trillion to spend on the right things, on health care. This chart shows you where some of that overhead is. If you give $1 worth of premiums to an insurance company, they'll hang on to 20 cents and pay out 80 cents to doctors and hospitals. If you give $1 worth of income to a self-insured employer like 3M or Cargill, what self-insurance means is they've already told the insurance industry, goodbye, we don't want to pay your overhead. We will set aside enough money every year so that we, the big company, can pay the medical bills of our employees as they come due. Those are called self-insured employers, and their overhead is about 10%. Still way above what a single payer is going to be. The traditional Medicaid program in Minnesota and in other states, that is before they started turning over the task of being insuring poor people to the insurance industry. Back in the days, say prior to 1996 in Minnesota, before we privatized Medicaid and turned it over to Health Partners and Blue Cross, their overhead was 4 to 5%. Traditional Medicare, the traditional program, not the so-called Medicare Advantage program, has been drifting toward 2 and 1.5% for the last 3 or 4 decades. It is around 2% now. It actually got under 1.5% 2 years ago. And ask yourself, why would the overhead of traditional Medicaid be higher than for Medicare? Answer, we make Medicaid enrollees prove that they're poor enough. And so if we want to hire people in the Medicaid office, DHS in here in Minnesota, to ask people whether their pickup is for recreation or for work and all that stuff, it means it drives up the cost of overhead. So that's why the Medicaid program, but even Medicaid beats the heck out of the private insurance industry. And here's an interesting little fact. Taiwan, we had a report published a couple of years back saying their single payer system at the national level has a 1% overhead. I think Canada's is around 2%. And I suspect that's because Canada is such an enormous country with relatively few people in it. Here is some data on how hospital administrative costs drop under single-payer systems. The average American hospital spends 25% of its revenues on overhead. Enormous billing departments that make their pediatrics and other departments look small by comparison. In Canada, the average overhead of a hospital there is 12%. England, under Thatcher, got a little bit messy. They're at 15%. Scotland is a fairly true single-payer system. They're at 12%. The Netherlands is a universal system, but they funnel their money through insurance companies. And you can see that because they have more uniform rules, they regulate their insurance companies heavily, they've managed to get their overhead for their hospitals down to about 20% of overhead, but it's a lot higher than a true single-payer system. So, again, if you're asking, how do you get 30% of a $3.5 trillion bill down, 30% spent on administration down to 15%, here's another piece of the puzzle. Hospital administrative costs go down as well. And here's another interesting fact I just got from the president of the Missouri chapter of Physicians for National Health Program. You can't read the source here, but he went directly to Canada to get the latest information on the overhead of Canadian physicians. And you see in that right circle that their overhead is 28% compared to 55% for an average American physician. So as you think about where that enormous savings in administrative waste comes from, think insurance company, 20% down to 2%, think hospitals dropping from 25 to 12%, think physicians dropping from 55 to 28%. And we haven't even talked about nursing homes and other types of providers. I want to just show you this little chart because it was Dr. Ed Weisbart in Missouri who sent this one to me. I was intrigued by it. This shows you that American physicians are starting to move to Canada, and it began around 2006. Now, there's not a lot of physicians we're looking at that used to be 500 a year moving, and now it's approaching 800 a year moving. It's a small percentage of all physicians, but I suggest it's sort of the canary in the coal mine. Physicians in this country they're burning out, they're getting depressed, they're feeling micromanaged, they're feeling their autonomy has been robbed from them, and they're moving to Canada because they hear they don't have to deal with Aetna and health partners, and increasingly even Medicare has been overcome by this urge to meddle in the doctor-patient relationship and make the doctor click on a box and say, did you tell the diabetic not to smoke? So this will be an advantage of a single-payer system that I think we need to talk about more and more and more. If we don't want to, if we want an adequate supply of physicians, we have to stop burning them out. We have to start treating them like professionals. You've already seen this. I now want to talk about selected sections of 1384, that's Pramilla's bill. S1804 is Bernie's bill. 676 is the former single-payer bill in the House, and 1125 is the new number of John Marty's bill in the Minnesota Senate. And I hope you enjoy this. I think people are intimidated about reading legislation. I'd like you to feel comfortable, and I'm going to show you some actual language. And we're going to look at these topics. As I said, a really true single-payer bill will have a provision that says, insurance companies, you're done on such and such a date. You can cover stuff that's not covered, but you're not covering anything that is covered after a certain date. I want to talk about the definition of institutional and individual providers. I want to talk about budgets for institutional providers and fee schedules for individual providers. And again, I want to show you actual language from several bills. And then I want to compare Pramilla's bill and Bernie's bill on how they're going to set rates for providers. Pramilla's bill doesn't say you got to cut provider rates to Medicare levels. She only says when the Secretary of Health and Human Services begins negotiating the first couple of years with doctors and hospitals, use the Medicare rates as a guideline. That's what she says. She doesn't say reduce rates to Medicare levels. So here we go. Here's John's bill. On or after the day the Minnesota Health Plan becomes operational, a health plan may not be sold in Minnesota for services provided by the Minnesota Health Plan. Now I wrote health plan there because I want to call your attention to the slight difference when you get to Bernie's and Pramilla's bills. They use the same language. Bernie and Pramilla use the identical language. Prohibition against duplicating coverage. On date X, you see two nouns here. A private health insurer has got to knock it off, and an employer can't offer coverage to their employees. Let me see if I got, yes, let me go to HR 676. HR 676 had a very simple ban. Unlawful for a private health insurer to duplicate. Now come back and look at John's bill. He talks only about health plans, and he doesn't say anything about employers. I bet some of you know why.
Scare everybody wants to
A federal bill called ERISA. The Employee Retirement Income Security Act, passed in 1974 at the federal level, says states cannot impose upon employers requirements that make it hard for multi-state employers, Fortune 500 companies, to create uniform pension plans and uniform health insurance plans for their employees. So you can see the problem. If Arkansas doesn't require maternity coverage, but Minnesota does, and you are ExxonMobil or 3M, your job is a little harder. That was the rationale for ERISA, the Employee Retirement Income Security Act. It's a mess of a bill, and the Supreme Court, it's like trying to imagine the sound of one hand clapping to talk about how the Supreme Court has interpreted ERISA. But pretty much everybody says, if John had written into the Minnesota bill what you see here in HR 1384 and S8, an employer has to stop doing that, that would probably be a violation of ERISA. But we think, and we've talked to, for years, we actually talked to Skip Humphrey when he was AG about this, and single-payer advocates in Ohio in the 90s approached their AG about this. What we're told, and I think it's correct, is you're fine at the state level if you say what John has said, which is you're only going to tell the health plans what they can and cannot do. We're not going to tell 3M what they can and cannot do. But who in their right mind, as 3M, is going to say, oh, God, we enjoy paying $10,000, $12,000 a year for each employee's insurance. Let's sue to have that, to continue that privilege.
Well, they use it for recruiting, but I am kind of into this because I'm a General Mills retiree.
Well,
and then when you work for General Mills, like they have excellent health care. We have I have my own cardiologist when I had high cholesterol. It's right on site. We have a clinic, we have a fitness center, we have all these wellness programs and blah, blah, blah. And then they'll cover you on that insurance until you're 65 when you go on to Medicaid. But what they don't tell you then is they like to fire anyone who's sick. So they like a young, healthy population. That's part of how they keep their healthcare costs down.
That's another reason for universal coverage.
Yeah.
Is no more sneaky discrimination against sicker people or older people.
Yeah, like if you smoke, they might not hire you.
Yep. Yep. So it just
DUI, they're not going to hire you.
So I just want you to be aware of that. But this is readable, right? You can read that. You understand that. Now I want to come to this definition of institutional and non-institutional providers. And when we start talking about this issue about how to deal with for-profit providers, those of you who followed this debate for a while probably know that HR 676 has long had a provision in it that says for-profit providers will have to convert to non-profit status. I never thought much about it. I just thought, okay, that's a good idea. Profit's a problem. But now that I've started to look at the issue, I have 1,000 questions, and I'm totally up in the air. And if any of you have any bright ideas, I'm going to throw the questions out to you today, and I want you all to start to think about it. All right, so here is the language in John Martin's current bill, Senate File 1125. An institutional provider means an inpatient hospital, nursing home, et cetera, and I've highlighted, that provides overnight care. Now, I don't know where John got that idea, because I sat and helped him write the current version of the bill back in '07. I don't recall having that discussion. I'm glad he did that, because I think we have to be fairly precise about what kinds of entities we want to be budgeted, as opposed to be paying a fee for service. And then he says a non-institutional provider means individual providers, and he makes a point of listing some entities, including imaging centers, that I suspect that Bernie's bill and Jayapal want to give budgets to. And I know this is going to be a little confusing, but bear with me because I'm confused about this. And here's how John's bill would pay non-institutional providers. It's very simple. That's Section B. They will pay doctors based on rates negotiated with providers. Now notice that that's very different from Bernie's bill. Bernie's bill says they're going to be paid Medicare rates. I think this is better language. We want the single payer board to negotiate with individual healthcare, the representatives of healthcare professionals. I'm a little reluctant to try to stare into a crystal ball and say, we think come 2025, Minnesota docs should be paid 112% of Medicare rates. This just makes more sense, to me anyway. And then John's bill says payments to institutional providers shall be by annual budgets. They'll be split into an operating and a capital budget. And this is a new provision. This last sentence is a sentence that the Minnesota chapter of PNHP recommended to John about 4 years ago. We're so concerned about the merger madness in our healthcare system. We've got hospital chains in this country that are 100 hospitals long. Alina's got, what, 14, I think Mayo's got 14 or 15. That's the name of the game, to get big. And our concern was, at the time I was on the Minnesota PNHP board, our concern was that if we didn't say specifically in the single payer bill, you're not, single payer board, you're not going to set a budget for a 14 hospital chain. Because you lose local control. And you're all aware that Mayo decided totally on its own to close down the OBGYN, the baby delivery services in the Albert Lee Hospital. Some CEO in Rochester made that decision. And you know darn well the Albert Lee people have no info on that. That is, one of the advantages of a single payer system is we get control over the allocation of capital and where services will be. And hospital shortages are becoming a more and more serious problem, particularly in rural Minnesota. So John, at our suggestion, thought, yeah, that's a good idea, and you see the prescription here. The single payer board shall set budgets for individual hospitals. We have 140 hospitals here in Minnesota. We'll have 140 budgets, not one for Mayo, one for Alina, etc. That prescription is not in HR 676 or Pramilla's bill. And none of those federal bills actually define what an institutional provider is. There's nothing that says it consists of nursing homes, hospitals, and hospices because they provide overnight care. I think it'd be a good idea to say something like that. Here you see the old definition of institutional provider. It just says, it uses the term institutional provider and then says, such as, blah, 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 about a half dozen things. I, for one, don't know why you would want to pay a dialysis center a budget. I think you all know the argument for hospital budgets, right? They provide so many services that you don't want nurses keeping a price tag on every bandage, on every drug. I've actually seen pictures, I don't know, Ann, if this is how it works, but where nurses are walking around, they're keeping price tags on their uniforms so that when they get to the computer, they can enter in all of this stuff. And hospitals provide myriad services. It just makes more sense to treat them like a library or a fire department and not pay for all that data collection. Now, is that true for a dialysis center? I don't think it is. But I'm not an expert on how many services a dialysis center pays, has to keep track of. So I question why we don't have a tighter definition of an institutional provider. That was HR 676. And here is Pramilla's bills. Her definition of how we're going to pay institutional providers is we're going to give them a budget. But again, you see a slightly different list of entities. What's in here? Dialysis facilities. Yes, now that's in here, whereas in HR 676 it wasn't. Well, who decided to add dialysis facilities to the list of entities that get budgets? I'd like to know that. Here is Pramilla's bill on paying individual providers. She's saying, and you see, she doesn't use the word individual. She says a provider not described in section 611A. Well, we just looked at that. Here's section 611A. It's this motley collection of institutional providers. And so she says, if you're not one of those, then you're going to be paid on a national fee schedule. And look at the red words down there at the bottom. In setting this uniform national fee schedule, the Secretary of HHS shall take into account the amounts paid under Title 18, that's the Medicare law. So that's fairly flexible instruction, right? She's not saying what Bernie says, which is you have to get down to Medicare's level. Same with hospitals. She uses slightly different language about how to pay hospitals. The Secretary shall use existing, this is the purpose. Medicare pays hospitals now with something called diagnosis-related groups. So if you have a hip fracture, heart attack, there are about 500 of these, and they're paying hospitals now on a per episode basis. And this section from Pramilla's bill simply says that when the Secretary starts negotiating budgets with the nation's 5,500 hospitals, he or she shall use current Medicare payment as a comparative payment rate. Now, you know, you can make as much sense of that as I can. They're basically saying, use your judgment, we'll figure this out as we go. And I think that makes sense. One of the great things about Pramilla's bill is that it repeals a whole bunch of junky programs that are called pay-for-performance or value-based payment. Now that's jargon, I think, to a lot of people. I hope I have time to explain some of that to you. In particular, she says we are repealing the Medicare Shared Savings Program. That's the name of the ACO program in Medicare. There are now about 1,000 ACOs in this country trying to become their own little HMOs. It's just another layer of insurance company. They have not proven themselves. And I really want to take some time to talk to you about this hospital readmissions reduction program. That's another program that's been inflicted upon Medicare by Congress. They're punishing hospitals if their 30-day readmission rate is above the national average. And it made no sense when it was enacted because there was no evidence that hospitals really have control over most of the important factors that bring sick people back to the hospital within 30 days after discharge. Yes?
Would you just tell, what's an ACO?
It's an accountable care organization. And it drives me nuts trying to explain it to people. But I'm hoping we'll have some time here. You can think about it, someone who's described it as HMOs in drag. Yeah. That's as good a definition as any. And to bless her heart, Pramila also explicitly prohibits HMOs and ACOs. She does it by saying you can't qualify as a provider if you don't give services directly to individuals. And so we've got too many people have gotten in the habit of referring to health partners as a provider. No, you're not. You're an insurance company. Doctors and nurses provide, not you. And again, we were worried that she was going to endorse ACOs. This was such a treat to read this bill and see this provision and to see that she explicitly repealed the ACO provision. Now I want to come to a tough issue.
Can I ask one question before you pass that other subject?
Sure.
I thought that regulation or rule that hospitals would be fined, I thought that came with that living at home or remain in your home, because that's how they implemented it in the state of Minnesota, that they placed people in the hospitals to check out people when they left, to make sure that they had everything they needed when they got home so that they would not come back to the hospital. So I'm surprised that it was a federal thing. Because Governor Dayton put that into effect.
I'm not familiar with what that is, but what I think she's asking about is, didn't we, in Minnesota at least, attempt to do a better job at the point at which patients are discharged to make sure they understand what drugs they're supposed to take?
Yeah.
And some hospitals are actually calling people up.
Right.
Congestive heart failure patients are getting called and they're being asked, can you breathe? Are your feet swelling? And that is helping minimize reductions. But the problem is that that's nowhere near enough to control readmissions within 30. I mean, 30 days is an arbitrary time. They could have picked 90. They could have picked 60. They picked 30. Mm-hmm. And it turns out that even though hospitals are trying to do precisely what you're talking about, they have been unable to reduce the 30-day readmission rate. And guess which hospitals are being penalized? It's the safety net hospitals. Mm-hmm. It's HCMC. Mm-hmm. It's the hospitals in poor rural areas and in inner cities. Why? Because they are treating people who have much less support at home, who, because of their life circumstances, are less likely to survive a heart attack or pneumonia or whatever it was they were discharged for. So we've gotten the worst of all worlds from this hospital readmissions reduction program. We're starting to kill people, and that's, I brought some research with me that's been published in the last year, and particularly the sicker people, because hospitals now have an incentive to try to keep you out for at least the 31st day, and then we don't have to report to CMS that you were a readmission. Yes?
So I worked in healthcare for 23 years, and one of the problems I saw was the DRGs were causing hospitals to discharge people faster because they only got paid a certain amount for an average stay. So if somebody had complications, sometimes they could end up losing money on that.
Yes.
So then they came back with the penalty, but the DRGs are what caused it in the first place by having that.
DRGs?
That's
Yeah, let's not-
This diagnostic
Yeah, let's not get too deep into the weeds on
Let's
this
not
one.
get
Let's
that.
do-
So that was part of it. So I worked in a nursing home, they would discharge people that were dying on route.
Yep,
We used to get them, they wouldn't even make it to the nursing homes.
yeah, yeah.
And
And
that was an issue.
in a single payer system where you've got a budget, I mean, what happens when crime goes up because we didn't budget enough for police? Or what happens if houses burn down? You hear about it because if a fire department lives in a fishbowl and it's run by a city council that lives in a fishbowl and you have access to the city council, all these other decisions, shutting down the delivery department, that gets made behind closed doors. So a lot of, I'm not saying these problems go away immediately, they become highly public under a single payer system. Now I want you to wrestle with this issue about for-profit versus nonprofit. If you have followed the national debate about single payer, you're aware that there is a provision, there has been a provision in the old HR1384 that says for-profit providers. They use two different words. This is part of the confusion. For-profit providers, alternatively, investor-owned providers. Now that's already confusing to me. Pick one phrase and stick with it. But the old HR1384 says for-profit providers must convert to nonprofit, and then it says when investor-owned providers convert, they shall be paid a reasonable price for their conversion costs. Now, I never knew what that meant. Here in Minnesota, when we drafted the early single-payer bills, we didn't say anything about for-profit or nonprofit. Part of it was we had never thought about it, and one reason is out of Minnesota's 140 hospitals, only 2 are for-profit. Now, the ratio of nursing home for-profits is considerably higher, and I don't know what it is. At the national level, 20% of all hospitals are for-profit. And I think it's 11,000 out of 16,000 nursing homes are for-profit. So it's an issue. Do we really want to be paying these institutions to make sure the dividends stay high for these stockholders? Of course not. We want this out. The question is how to do it. And I'm going to tell you a thought process I've been through over the last week, and at the moment I'm flummoxed. And I'll tell you what my problems are. First of all, okay, so I want to talk about this definition. Why are we using two different words, for-profit versus investor-owned? When I hear for-profit, I think it means the 2 women who work in my the 2 dentists who work in my dental office. They have families to feed. They have to take in more income than they pay out in order to survive. Is that profit? Yes. Is that what we're talking about? Are we talking about buying them out? I don't know. But the word investor-owned, what if one of the dentist's husband bought the clinic, but he doesn't work there? He's a teacher somewhere. Isn't he a passive investor? He's not on salary. He's never sets foot. He just put out the money so the 2 dentists could buy the office that I go to. Isn't that a passive investor too? I think it is, but I couldn't tell you for sure based on the language in HR1384 that it's not. As you may be aware, National Nurses United, which got started in California as California Nurses Association, and then, I can't remember, I think it was the early 2000s, asked a whole bunch of state associations to join them in creating the National Nurses Union, and Minnesota's M&A was one of them. I think Massachusetts joined. I forget others. But at this point, they have 125,000 nurses. And they have long held the position that this buyout provision, this section in HR1384 that we have to buy out any investor-owned for-profit entity is a political nightmare. And I've never heard them lay out a good argument for what's wrong with the PNHP proposal. PNHP essentially wrote the old HR676.
I don't know if I agree with that. If you think of this company called Extendicare, and they're from Toronto, and they're in the US, Minnesota and Michigan, and they're buying up like rehab facilities. Like you have a stroke or you're in a car accident, and they're listed green to buy on the New York Stock Exchange. So to me, that's investor-owned healthcare.
Yes.
So
Yes.
that's what they're talking about here.
Yes. And my question is, as you think then about HHS buying out, reimbursing these people for the reasonable expenses of converting to nonprofit, what does that mean? I didn't know what it meant to PNHP until November. In November, David Himmelstein and Steffi Woolhandler, the co-founders of PNHP, published a short article on the Health Affairs blog in which they revealed what they think it means. They think it means buying out the stock of hospitals, nursing homes, and dialysis centers. And I'll give you an example of what of one of the companies they proposed. Here, this didn't show up very well, but this, and David and Steffi measured the cost of paying these for-profits for conversion by looking at their market capitalization. Market capitalization is measured by, you take all the stocks times the price the stock is selling at. And so here's not a very good picture of the performance of Tenet Healthcare's market capitalization between 2015 and 2016. You can barely tell here, but in the middle of 2015 and 2016, it peaked at $6 billion. It fell at the low point to about $1 billion in 2018, rose again, fell, and between January of this year and Friday, it went from, did I write it down? Oh, I didn't. It went from a little under $1.5 billion to 2.5 over the space of about 6 weeks. According to what they're saying, the Treasury Department would buy out Tenet for some number. Right after Friday, it was $2.5 billion. Now, what happens when anybody, a government or another business, buys the stock of a for-profit company? You own the damn thing, don't you?
That's called fascism, isn't it?
Well, it's called, it is really a government takeover, is it not?
Yeah.
I mean, in my mind, I'm suddenly thinking, oh my God, the right wing will say any effort reform is a government takeover. And are we not now actually promising to buy 1,200 of America's 5,500 hospitals? What am I missing? And I've only begun to ask people in the last week. And nobody says, God, Kip, you're wrong. If you get any brilliant insight as to what this means, I think it's what it means. And if we don't define the entities that we want HHS to buy out, are we talking about buying out my dentist's office? Now, I think I'm getting silly, but I don't think we are. But where does it? I think we need a lot more definition than we've got here. Now, let me back up and just show you the language, so you can wrestle with this yourself. Here is the old HR676 language. We just read the first sentence. No institution may be a participating provider unless it's a public or not-for-profit institution. Okay. So you see the word there is, then they use the word investor-owned. And then they say the conversion, you shall be for-profit, and then they use the word investor-owned in the title, so I'm not sure which we're talking about, shall be required to convert to not-for-profit status. Well, if we're going to buy out the stock of Tenet, how do we convert it to not-for-profit? We have converted it to a publicly owned hospital, have we not? So I am mystified by the language.
Well, what is the legal definition of non-profit? Because non-profits still make money.
Yes.
So this is what's puzzling to me, I'm not an attorney or anything. What is the legal definition of nonprofit? What do you have to do to qualify?
If you ask me, it's your status with the IRS. There's a very clear definition. There's a lot of people abusing their tax-free status as a nonprofit, but there's a fairly clear definition. The most important rule, according to the IRS, is you cannot pay your managers and your officers an unusual amount of money, and you cannot issue contracts. You can't have somebody replace the roof on the hospital for insane amounts because you're contracting with your relative. Essentially, the major rules against that nonprofits have to obey. For-profits can do pretty much whatever they want to. And just to amplify on this, nonprofits have begun to act a lot like for-profits in the last 20 or 30 years. And I think a lot of the problem is this merger madness. I think a lot of the problems we're seeing with nonprofits is they're being run now, like mail. Profits are being run from far away by people who are not in connection with the local community. But you ask a good question. I don't know the answer to that. And I don't know what investor-owned means. Before I came over here, I looked up Cargill. Cargill is a great big meat, they may be into petroleum, mainly an agricultural and meat company. They are privately owned. But apparently they have stock. So are there hospitals that are like Cargill? They're not publicly traded on the New York Stock Exchange, but they are held by passive investors, people that don't set foot in the Cargill headquarters or plant, but are they not a passive investor? And there must be a lot of those in the healthcare industry as well. I hope I've summarized for you my confusion. I don't know what the answer is. Well, here's what the new bill says. The new bill does not say we are going to buy out investor-owned entities. They say all we're going to do is instruct HHS that you will set rates for nonprofits for for-profits at the same rate that you pay nonprofits. That to me makes a lot of sense as an interim measure. Now we can all think of problems with that too. You can imagine for-profits trying to be evasive in some way, game the system. But in any event, that's what Pramila decided. When she rewrote HR1384, she took out the ban on for-profits and she said, no, we're going to regulate it. And I'll leave it for you to think through which is the better solution. I think we can predict that if a for-profit knows that a new law is coming and that HHS is going to be setting their rates at the same level of a nonprofit, I think we'll see shareholders pull their money out and we will see the value of the shares drop, people will see handwriting on the wall, and they may want to convert to nonprofit status totally on their own. But exactly what happens after that, I don't know either. It might be, this might be the happy outcome. Pramila's bill passes, stock prices drop on all the for-profits, and eventually they want to sell out to people who really do want to run a hospital and not make a lot of money, and everybody lives happily ever after. Now I'm going to summarize, I'm going to take 5 minutes to summarize Bernie's bill, the problems with Bernie's bill, and we'll stop and take questions. Here's the problems with Bernie's bill. It has no hospital budgets. Now who got to Bernie and said, yeah, let's make American hospitals have 25% overhead instead of 12%. Why is that a good idea? Well, the reason I think it's a good idea is he got into his head that we need ACOs. In case you can imagine, if you think about accountable care organizations, they are essentially a lineup. They've got an accountable care organization contract with both our Department of Human Services for Medicaid, and they used to have one for Medicare. I think they dropped out. They just were losing money on it. So what are they, a 14 hospital, 50 clinic chain? They are, so how did Aligna become an accountable care organization? If we've got time, I'll tell you the irritating history of this silly concept. But essentially what Alina does is they sign a contract with the Center for Medicaid and Medicare Services, CMS, the agency that runs Medicare. And the contract says, we, Alina, agree to have you, CMS, assign patients to us based upon whether they've had contact with our primary care doctors. It's a silly algorithm they use. And then you, CMS, will crank the names of these patients into a computer, and based on the previous year's claims, you will estimate what these people should cost next year. And then if we go over that, we will split the losses with CMS. If we go under it, we split the savings. Alina will get some extra money to do God knows what with, but if they go over it, they split the losses. And the concept is called shared savings. And that's one of the programs Camilla is repealing. Bernie must have gotten it into his head that he wants lots of Alinas and Mayo Clinics and Essentia and Sanfords and all these chains. And so ask yourself, if the chains themselves consist of most of a state's hospitals or a country's hospitals, or even a substantial portion, how then do you do hospital budgets and sign these ACO contracts with the big chains? It is an unbelievable message to try to think about doing both, and I think Bernie realized that, and he said, to heck with it, I'm not going to do hospital budgets, we're going to do this shared savings game with ACOs. There was no reason to do that, other than it's all the rage and has been for the last decade. But he sacrificed a known policy, hospital budgets, for a policy that at one time was sort of unknown, and now we know it doesn't work. It discriminates against sicker and poorer people, and it's not saving Medicare any money. The section that Bernie has to get rid of, it's a single sentence in his bill that authorizes this nonsense with ACOs. What you see here, I've put in red. It says any payment reform activities or demonstrations that are currently going on in Medicare shall be inflicted on the non-elderly when my bill becomes law. That's essentially what Section 611B. And so amongst the payment reform activities are ACOs, the Shared Savings Program, the Hospital Readmissions Reduction Program, which we were just talking about is starting to kill sicker people. That is one of the payment reform activities that's going on in Medicare. So in a single sentence, Bernie is essentially proposing to inflict on the non-elderly some programs that are risky and not saving money for the elderly. And everybody I've talked to said he added this in the last 2 weeks, late in the summer of 2017. He introduced the bill, I think September 13, 2017, and this got added in the last 2 or 3 weeks. We really need to encourage him to get rid of that. I think I will stop here. If you've got more questions about, there's a number of issues we have not discussed. Pramila's bill will override the Hyde Amendment. I think I can show you the language. It's a little bit difficult to follow. But I'll stop there and take questions. Yes?
Yeah, I was wondering, how does Medicaid fit into this when people that are disabled need care and people at home and a lot of services?
Under Pramila's bill, Medicaid disappears. It's just...
So it'll be inclusive?
Yes.
Okay.
Yeah.
And another thing is the dental mental thing. What happens there? Is that in the Medicare bill too, her bill?
Are you asking, does Pramila's bill cover dental?
Well,
and mental health? Yes.
Is the mental with Medicaid, or is that
Medicare? No, Medicaid goes away, Medicare goes away. The only existing programs that stay are the VA and the Indian Health Service. And I think mainly those are political reasons. They don't want the vets getting upset. They don't want Indians. I don't know why vets or Indians get upset about those programs. There may be defenders. The VA here in Minneapolis is fantastic, but the VA, I just don't think that you want any group segmented off We want everybody in,
So
nobody out.
mental would be included.
Mental health is included, dental is included. One of the issues with Bernie's bill is that he leaves nursing, not skilled nursing facilities, but long-term care with Medicaid. And he says the states will continue. He said his bill basically says Medicaid is done with the exception of unskilled nursing facilities. And people who need that under his bill will continue to get it through state Medicaid programs. That upset a lot of people. Pramila just said, to heck with that too, we're getting rid of all of Medicaid. Yes?
Do you have any idea who's advising Bernie on all this stuff?
I would love to know that.
Well, isn't the nurses union really closely tied with him?
Yes.
So they should be influencing him.
So everybody hearing the questions, who's advising Bernie? And you're saying the National Nurses Union is very close with him. That's absolutely true. And here's what I know about the National Nurses Union's position on this Section 611B. They said they didn't know. I actually met Michael Leidy, their chief policy guy, in June at the single payer conference that was put on in Minneapolis by Healthcare Now. He swore up and down that he didn't even know 611B was going to go into Bernie's bill. He learned about it after he read the bill when it was introduced. And according to California PNHP, the new president of NNU, Bonnie Castillo, told him they are lobbying Bernie to pull 611B. Now, that doesn't tell me what I really want to know is, did you promote ACOs? Because ACOs are only a part of this menu of bad ideas that 611B supports. And for many years, the California Nurses Association supported an enormous loophole for Kaiser Permanente, a gigantic HMO located in the West in Hawaii. And they wrote a similar loophole into the Maryland so-called single-payer bill. I don't know if that's changed. I'm just telling you I know that history. Yes?
I think the rationale for keeping the Veterans Health System and the Indian Health Service separate is that they're really a different model. In those cases, the public owns, or the VA Health System owns the facilities, and those employees are federal employees, as are Indian Health Service employees are public health service employees. So it's kind of a different model. I personally am comfortable with keeping those two programs intact and separate. I mean, maybe eventually you could merge the money, but for right now, it might be simpler.
What upsets me is the number of horror stories we have to listen to. That's a wonderful institution,
right,
and it constantly gets underfunded.
Right.
That's what bothers me.
And it's a little bit of a mixed system because there are a lot of Native Americans who are Medicaid. They're covered by Medicaid. Also, a lot of veterans go to local facilities and the government pays for it. So they're all mixed.
Yes.
And that's interesting. We can talk more about that later. But I've recently heard that Native American health service is horrible. What's happening is so many of their facilities have closed, very similar to the rural hospitals and things, that these people are literally dying because they have nowhere to go. So they have no access. So I'm thinking that we need to educate these people, and they would be on board with this in a minute.
The new president of Minnesota, PNHP, would agree with you. His name is Brian Yablon.
Oh, yeah.
He's a wonderful guy.
Yeah.
What is he, ER and HCMC? Hospitals.
Well, and a lot of Native Americans are covered by not only Indian Health Service, public health service, but also by Medicaid, also by the federally qualified health service. They're not covered by.
But anyway, I think that's something that we can get.
Yes.
Get this.
Would a federal program override a state program like John Marty's? And my question is, does it make sense for individual states to start promoting their own programs that might be able to spread rather than just pushing for one federal program?
Her question is, would a national bill override a state bill? And in the meantime, does it make sense to push at the state level I presume, support national legislation. That's exactly what Minnesota PNHP does, and that's Healthcare for All Minnesota, which is the group that many of us are a part of, this chapter is a part of, are supporting. We're really more emphasizing the Minnesota single-payer bill, but when we have the opportunity to comment, the whole world wants to know what are we thinking. We're eager to promote a good bill, so we intend to comment about this bill. But to answer your question, I think there are some people that really frown on state-level activity. I'm not one of them. I think none of us have a crystal ball that allows us to figure out, will we get to a national Medicare for all single-payer system by concentrating solely at the national level versus focusing at the state level. And as you all know, I think, Canada got its single-payer system province by province. And I just, given my experience as a community organizer, I crave issues that give you local handles. I don't want people to have to go to Washington, D.C. in order to feel actively involved. It's a lot easier to plug people into activities when you've got something local like Minnesota bills. And this chapter has been part of it. Paul and I were just talking about some of the things you guys have done. You're meeting with local legislators to educate them on these bills. Don?
Yeah, I'm just wondering if it's politics on the Senate side, U.S. Senate side, and on the House side that's keeping the Bernie bill with the ACOs, it being the more now conservative body. And we now have a Democrat House, and maybe that's helped to get Jayapal's bill without the ACOs and incursions of the insurers. And so eventually the two bills are going to be coming to conference committee, and probably one of the worries is to really work on Sanders somehow to take all the ACOs and those compromises out before it goes to conference committee. Because then there's the danger of the Jayapal bill being compromised in conference.
Yes. Don's observation was it's conceivable that the defects in Bernie's bill are there because the Senate is more conservative than the House. And it really is important to get Bernie's bill straightened out, because you know if you get into a conference committee with Jayapal bill and Bernie's bill, there will be some compromise. And some of this stuff that I've been criticizing, they will have to compromise in some fashion and put some of that stuff into the final bill. Let me just tell you this. I think Bernie, he's from Vermont, and you may all recall that Vermont was one of the first states in the news trying to pass a quote-unquote single-payer bill. But they never worked on a single-payer bill. What happened was William Zhao, a widely respected economist who helped Taiwan set up its system, made a recommendation to the Vermont legislature in February 2011. You should go to a single-payer system, and you could even save more money by injecting ACOs into it. I mean, it's an oxymoron of all time. And here's a respected man who had helped Taiwan go to a single-payer system in, what, 1994, 1995. And he is saying that a multiple ACO system would get the savings that you'd expect from a single-payer. And all this, and PNHP invited me to testify in front of the Vermont legislature, and I couldn't fly in, but I did testify by phone in front of the Senate Vermont Health Committee 1 month after that awful Zhao report came out. And I gave them all the reasons why you don't want to support ACOs. In the end, nothing passed, but Governor Shumlin took up the baton, and he started saying, I'm a single-payer advocate, and we're going to have all these ACOs. and then, when Shumlin gave up around December 2014, what did the media report across the nation? Single-payer failed in a blue state like Vermont. It's never going to pass anywhere. And so we're paying what's happened in Vermont didn't stay in Vermont. And that's why I think we should be concerned not only about Bernie's bill, we need to be concerned about state bills or proposals like Vermont. You may all recall that one of the DFL gubernatorial campaign candidates, Rebecca Otto, was proposing a single-payer bill, and she was going to put ACOs in it. And she went to John Marty and said, I want you to to back me up. John refused. He said, this is not a single payer bill. And she actually said to him, well, but California has this big HMO loophole in their bill, and they're calling that single payer. And John said, yeah, that's their business. We're not going to do that here. You can see the problem we face if we can't get people. I get it. If Californians think they can't pass a universal coverage bill without an HMO loophole, then God bless you. Write the loophole. But don't call it a single payer. What skin is it off your nose to call it something else? But they had to call it a single payer.
Why didn't she come to someone like you? I think all of us in this room need to say, if you don't speak to people like you here in the state that know about Marty's bill, we don't want it.
Well, that'd be nice if they would come to us. She knows me, she knows who I am.
Yeah, I know, and I was one of the people that told her that. I think other people in the room said the same thing, and we love her as a person,
Yes.
and would have liked to see her back something a lot
Me too.
better.
Yep.
She stood firm on that, I mean, all the way to the end.
Yeah.
I don't think she got it.
Could you just clarify for me, maybe I've missed it, how would a single payer be actually paid for? Would it be paid for out of, is it proposed out of general taxation? And would that general taxation be actually come more from those who are making all the wealth rather than those who aren't?
His question is, can we talk about how a single payer system would be financed? What are the taxes that will pay for it? And I think we were here when I said in the beginning, one of the weaknesses of Jayapal's new bill is she stripped out 4 progressive taxes that were in HR 676. And Bernie did the same thing 2 years ago. There's just no information about how Bernie or Pramila proposed to finance their bill. And I think that's not a good idea. I think they made the judgment that it makes the bill more passable. HR 676 had 4 progressive taxes, a surtax on the income tax. I think they had a sales tax on stock transactions, 2 others. Yachts, no, it wasn't yachts, but it'd be something that hits, it is progressive. John Marty has written his bill simply to say, we're going to finance single payer in Minnesota with a combination of premiums paid by individuals and taxes paid by business, and both have to be progressive. And that's it. He leaves it to the single payer board to figure that out.
So on the question of people actually, that contributory principle, really then, how does that apply if people have to pay a premium? What happens when they can't afford to pay a premium? Is he proposing that they get credits? Or, I mean, how does sort of premiums actually work out in practice? I'm not sure.
Now, we could write that into the bill. Again, that's one of those issues that we can debate whether we're helping or hurting ourselves by writing it in. Here's an example. We could write, progressive means to most people that you're not hitting poor people who can't afford to pay it.
Yeah.
That's what we're upset about by sales taxes. They hammer, everybody's got to pay it. A good single payer, or a good progressive tax of any sort would not even start till you've moved up to, I don't know what, 150% of poverty level, 25,000 for a family of 4 maybe. You don't, it blinks on at a certain level where, and then it's small, and it begins to creep up until you're at Warren Buffett, and it's a much higher number. That's what a progressive tax is. And it's a good question. Why would you want poor people to pay anything? That's why it's such an important part of any evaluation of a universal coverage bill. Because a lot of poor health is caused by poverty. Yeah. And it would be a horrific injustice if we were to pass a universal coverage bill and finance it by putting poor people deeper into poverty.
Yeah.
I gotta cut off first, if you don't. Just gonna hang around a little bit, but I gotta get Don to speak for a few minutes. We're at 3:32 now. And all good questions. I think there's one that I asked.